This is the kind of case study. You have 4 case studies in one. But they are very, very short. Ignore them and just look at it as individual patients put in the long case. So this is one case. Okay, you have one case. But within the case, they've given you 4 stems. And so pay attention to that. We're going to go through and I'll show you how to handle it. It's a form of prioritization, but the question is formed in the case form to deceive you to think otherwise. Treat each patient whatever they need, whatever question they ask you, treat them separately. So patient 1, it's a 35-year-old, and G1, P0, 36 weeks, is in labor, progressing well. But 5 minutes ago, client report of sudden onset of what? Abdominal discomfort. Exams revealed tense abdomen and loss of fetal station. This is the vitals: temperature, heart rate, blood pressure, respiratory rate, saturation. A bunch of buzzwords put together. You have to make a diagnosis and know what this patient is suffering from. Second case, second patient in the same case, 35-year-old male, admitted for gastric pain, nausea, vomit, NG2 placed, abdomen soft but distended with hypoactive bowel sounds, right? Currently, the client is NPO as an NG2 to low continuous wall suction. IV fluid is running 150 ml per hour. This is the client virus. The next assessment revealed bruising around the bilateral flank area. What do you think is wrong with this patient? Number 3, 35-year-old, obese, now post-Roux-en-Y gastric bypass, 23 hours ago, complaining of what? Abdominal discomfort and restlessness. Abdomen slightly distended, but guarding and tense. Incision, clean, dry, intact. It's a temperature, heart rate, blood pressure, respiratory rate. That. 3 patients so far. You have to figure out what is wrong with each patient before you can proceed with the case. It's one case, but this is the whole initial stem of the case. The rest will follow. It's like 6 case study, but you have 4 different kind of patients. The last patient, 35-year-old female, admitted with right lower quadrant pain, nausea and vomit. Y count 20,000. Client is awaiting surgery. Pain initially 10 out of 10. Now client is refusing pain medication because the pain is what? 0 out of 10. This is the temperature, heart rate, blood pressure, that. You have to figure out what is wrong with this patient. I made this patient, these cases are based on what I heard, but this is the way it was presented. 4 different patients in one case, and you got to go through the same 6 case information. But for all of them, you have to make diagnosis for each of them before you should be able to answer most of the questions they're going to ask you. Otherwise, you get confused. What do you think is going on with 1? What do you think is going on with 2? What do you think is going on with 3? What is going on with 4? And when you figure it out, you'll be able to answer all the questions they're going to ask you. So don't be disturbed. When you see that, just step back. You say, fine, I got it. I have 4 patients as if I'm doing prioritization. Analyze them, see who is sick, and manage the patient. Did you figure out what is wrong with this number 1? Did you figure out what is wrong with number 2? Did you figure out what with number 3 and number 4? I've given you a bunch of buzzwords in a short form to be able to. 35 is in labor. All of a sudden, there's a buzzword. Sudden onset of abdominal discomfort, tense abdomen, loss of fetal station. Your answer choice is here. Patient is tachycardic, hypotensive, Respiratory is going up. What is your diagnosis? Have you heard this before? Loss of fetal station, that is the key. Sudden onset, that is the key. And the patient is in labor. Loss of fetal station, sudden loss of what? Fetal station, patient is labor, and blood pressure is 80/60. Mid-epigastric pain, nausea and vomit. NG tube is in place. Signs of ileus, hypoactive bowel sound, receiving a lot of fluid. All of a sudden, bruising around the flank area. What do you think is that? Bruising around the flank area, bilateral flank area. Did you figure out what is wrong with you? 3, Roux-en-Y gastric bypass, abdominal pain, restless, distended, guarding, tense, incision, temperature like that. 23 hours of surgery. I'm showing you how you can answer questions by focusing on the buzzword. Forget about all the stuff. Take the 3, 4 information, and you'll be able to make diagnosis for this patient. Right lower quadrant pain, leukocytosis, nausea, vomit. 10 out of 10. All of a sudden, no more pain. Febrile, and this is the vital. Number 1 is uterine rupture. And number 2 is pancreatitis, who is bleeding. Bleeding from pancreatitis, hemorrhage. This is the key, bruising around the bilateral flank area. Pancreatitis, that is bleeding. Gastric bypass, 23 hours. Severe abdominal pain, restlessness, tense abdomen. You have to bring your content. And if you need content, how to read and understand your question and know your content without no being bored, check out that class. There's only 2 things you should worry about gastric bypass patient. I try to make content easy, simplicity. Every time you hear about gastric bypass, think about 2 things, only 2 things. Either they have pulmonary embolism after surgery, or what? They have anastomosis leak. That means they have peritonitis. So these patients look like he has leak, anastomosis leak, peritonitis. And of course, this is no brainer. Right lower quadrant pain, leukocytosis, nausea, vomit. That is what? Appendicitis. So you have 4 patients. Uterine rupture, somebody who's bleeding from pancreatitis, somebody who has anastomosis leak, and somebody who has appendicitis all of a sudden does not have any pain anymore. I said it so that you can think, you can learn how to understand this kind of question. So that's what you have. You spend time to analyze it, and you figure out what they have. You see, if you spend 2-3 minutes to figure out what all of them have, the rest of the question is become easy. You don't have to worry. Now I say highlight concerning finding for each. I already given you. So what do you think, based on your diagnosis, is concerning for number 1? What is concerning? Sudden onset is not good, right? Tense abdomen is not good. Loss of fetal station is not good. They will most likely in the exams highlight some facts and ask you if it's concerning. But I intentionally left that one out so that you can think about it, right? Sudden onset, loss of fetal station, tachycardia is not good. Hypotensive is not good. Respiratory rate is going up. Those are the things that is not good for this particular patient. What about number 2? He has mid-epigastric pain. It's not that bad. It's consistent with the appendicitis. But what is the problem? Oh, this nausea, vomiting. It's consistent with the pancreatitis, basically. It's not a problem, but it's tachycardia. The blood pressure is going down, right? His SAT is 95 on 2 liters, not doing well. And then he has bruising around the bilateral flank area. This is bleeding. So those are the things you should worry about. He's in respiratory distress and he's bleeding. 35-year-old obese, Roux-en-Y gastric bypass, complain of abdominal discomfort and restlessness. It's not good. It's a B-sharp movement. Abdomen distended, is guarding. Peritonitis. The abdomen is tense, bad. Decision is fine. You have temperature, you have tachycardia. It's not good. The blood pressure is still holding, so that's fine. So tachycardia, these are the things you should worry. Last one, right lower quadrant pain, nausea, vomit. Why can't this is all consistent with appendicitis? It's not that bad. But all of a sudden, 10 out of 10, yeah, it's not good. All of a sudden, pain is 0 out of 10. Then it's tachycardic. So if they ask you to highlight, most likely they will highlight this information for you, but you have to, if they're not you thinking about it, they most likely will highlight some key of them, but I intentionally decided not to give it to you so that you can look at it and say, this is not normal, okay? So this is not normal. So those are the things you should be able to highlight for this particular case. If they're not highlighted for you, they'll ask you, what do you think about it? It may be like select or apply. So those that is consistent with the disease, you let go. Those that is worrisome and creating the current condition of the patient is what you're going to pick. So that's the phase for patient. You see how it's very intimidating, but it's something you can do it without sweating, right? List one priority complication for each client. I told you, if you make the diagnosis from the beginning, the rest of the questions is easy. We already know what this patient is. We already know what this patient, all of them are. What do we think this is number one? It's a uterine rupture. What one complication do you think this patient will suffer from? Think about it. What do you think? What one complication? A lady in labor now as a uterine rupture. What complication do you think they will be suffering from? It's no brainer, right? It's going to bleed to death. I've given you blood pressure there, tachycardia. This patient is going to shock. What kind of shock? Hypovolemic shock. What kind of hypovolemic shock? Hemorrhagic. Hemorrhagic is a form of hypovolemic shock. I have a very good shock video on adaptant class. You have to join the membership to watch it. But that one is very good. Give you all the stages of shock and everything you need to know about individual shock. So hemorrhagic shock is a form of hypovolemic shock. Dehydration, yeah, it's a form of hypovolemic shock. So this is hemorrhagic shock. One complication for this lady, hemorrhagic shock. What about this patient? Bruising around the bilateral flank area, pancreatitis. That means what? You have pancreatitis, and this is the belly button. There's bruising here, bilaterally. This is what we call gray tenant sign. If it's around the belly button, we call it Kelly sign. This patient, what is going on with them, you already know. It's bleeding from pancreatitis. What one complication is going to happen to this patient? The same thing, hemorrhagic shock, okay, which is a form of hypovolemic shock. So that one too, the same thing, right? Number 3, obese patient, Roux-en-Y gastric bypass, restless, distended, and then temperature down. This patient is leaking. So anastomosis leak. Is going to have what? Sepsis. So you go into septic shock, peritonitis. So this patient go into septic shock. That's one complication. They may ask you more. They may ask you select one or two. They will give you options and you pick from. I intentionally did not want to give you that, but you think about what this patient will undergo through and what problem they will undergo. The last one, right lower quadrant pain. Why count of that? Pain, all of a sudden, no pain. The appendix has rupture, has developed what? Abscess. If developed an abscess, we'll go into septic shock. So we have 2 septic shock and 2 hemorrhagic shock. So those are the complications this patient will be undergoing. So it's the same thing, you know, but if the presentation is just like a different. So don't say, oh, the cases are long. I mean, it disturbs your morale and it affect your confidence level. Look at it at individual patient, put in the case, and answer the question the way they've asked you. That's all. That's all. That's what I'm trying to show you. Number 3, which client should be seen first? Now, if you know your B-sharp, whatever prioritization you know, whatever strategy you know to take care of the patient, it's fine. I'm good with that. But you have to understand that patient gets sick all the time. Time is not your factor. You can sick 3 days, 4 days. Don't tell me this is an acute and an acute. Look at the condition of the patient and what is happening, the diagnosis and the condition of that patient. That is what prioritization is. If you take care of the patient, you will know. If you start taking care of a patient, they get sick before even the day they're about to discharge. So take that time, 12 hours. If people have told you about 6 hours is crap, okay? There's no time when you can get sick even when you go home. So just know that. Look at the situation, look at the condition, assess it, put yourself in that situation. That is what it means to be sharp. You take care of hemorrhage, airway issue, take care of sepsis, you take care of all of them, the breathing, but then you put it together and you said, oh, okay, you have this and that to that. Which one is more serious? Which more do I have time? This lady who is in labor, who has a uterine rupture with the baby there. This patient who has pancreatitis and also bleeding from pancreatitis. The blood pressure is also low. That patient blood pressure is also low. You have to put everything into totality. Gastric bypass patient who has a leak is septic. Appendicitis also is septic. But think about it. Who is more likely to go downhill faster? That is what you have to think. Do you think these two, appendicitis is more dangerous than anastomosis leak? They all have sepsis, or is more dangerous than pancreatitis that is bleeding, or more dangerous by a uterine rupture? Think about it. And whatever your prioritization is, tell me which one you think you will see. If you are the nurse, who, when you have 1 second, who do you want to give that time to? I can tell you, based on clinical, based on experience, what I do, appendicitis, you have time. If it's ruptured, you have time. Their pain get better. You're most likely going to get a CT scan and then put them on antibiotic. They may already be on antibiotic and drain. This one, the same thing. We'll probably get a CT scan, prove that they have a leak, anastomosis leak. We get antibiotic. They may go to surgery or may not. Peritonitis, there's sepsis. This is the same thing. You got to prove that there's hemorrhage. It may be retroperitoneal hemorrhage. It's a priority. They are all priority patients. But this lady has no time. She's going to die, and the baby also going to die. I need emergent surgery, remove the baby, try to save the mother and the baby. So the one who is more dangerous is a uterine rupture. I give you 2 things. They are in shock. But you can see this lady blood pressure is too low compared to that. Her reserve is going down. You have to be smart and think about it. So number one is your priority. Should be seen first. She should be seen first. So that is the number one, who should be seen first. Now, like I said, you see the way the question is progressing. You already know it, but it's put in the different form. Now, have you seen this patient before? Teaching and intervention. You've done these questions multiple times, but this is in a different form. I said, which statement by the client need further intervention? You already know the first patient, right? You know the second and third and fourth. Uterine rupture. This is the pancreatitis patient. This is the gastric bypass patient. This is appendicitis. The first patient said, I will need immediate C-section. Does that need further intervention? Which statement made by the client need further intervention? So which one need further intervention? Number two, I will need heparin drip. You think that need heparin drip? Number three, more pain medication will manage my current condition. You think if you give him more pain medication, it will be fine. Number four, I don't need any surgery anymore because I have no pain. Think about it. Uterine rupture. She said, well, I will need immediate C-section. You think it's a bad thing? Pancreatitis, think I will need what? Heparin drip. You think it's a bad thing? More pain medication will solve my current condition. That is somebody who had what? Gastric bypass and the leak. And then appendicitis said, I don't need any more surgery because I have no pain. You know when the rupture is a problem. So you still may need surgery. So this guy need intervention. You sick from a leak. More pain medication is not going to solve your problem. You're going to be septic. You're getting pain not because of the incision. You're getting pain because of sepsis. Sepsis needs sepsis control. We need to intervene. You don't need heparin drip. You're already bleeding. This guy is bleeding from the pancreatitis. The bruising around the bilateral flank area is bleeding. If we give them heparin drip, they're going to bleed to death. Therefore, this lady needs surgery. Whether they're going to do C-section, the uterus already ruptured. They're going to remove the baby, but we need to fix something. So she needs surgery, so does not need intervention. 3, 4, 2, 3, 4, we need surgery. 4, sometimes all they need is drainage, but in your test, assume that, yeah, they may need some form of treatment to be done. So 2, 3, and 4 need something to be done. Like I said, don't get confused. It's the same thing. You've seen this teaching intervention, but if they present in this form, does not mean they're trying to make you confused. It's the way they're trying to put it. It's a case form. Go through the process. Like I said, I'm trying to think like the examiners. So I suspect this is what they will go through. In the 6 case form, they'll give you something like that. And you've seen it before in a single case. Indicated contraindication. It looked busy. I try to repeat the information. They will do that to bring the same question to you so that you don't have to go back and forth. We already know the case 1. I have not changed anything. Case 2, case 3, case 4. You know the diagnosis. Like I said, if you know the diagnosis, then the rest of the case is easy. Key in answering case study, find the diagnosis, know the content, and hold on to it like an egg. And follow every question and think in that perspective. Don't let them trap you. We said this is uterine rupture. Nothing has changed. We said this was what? Pancreatitis, that is bleeding. We said gastric bypass that is leaking, peritonitis. We said appendicitis that has rupture, abscess, is peritonitis. Then you tell yourself, how do I manage it? How do I manage it? That's all. How do I manage it? Well, if you have uterine rupture, do you put 26 gauge IV in? Do you put a CT scan? They get a CT scan, or they go to C-section? If it's indicated, you check it. If it's contraindicated, you let go. Think about it. The lady is going to be born, septic shock, hemorrhagic shock, uterine rupture. Where will she be? You want to put a 26 gauge IV in? Tell me. If you want to put it, that's fine. If you want to take the patient to go get a CT scan, just tell me. If you want to go to C-section, then do it. What do you guys think? Which one is indicated here? Which one is contraindicated? If it's indicated here, you check it. If it's contraindicated, yeah. So if somebody is bleeding, if I'm bleeding, don't ever put 16 gauge IV in it. What kind of IV do you need to put it there? What do you guys think? What will be your IV access? If the patient is bleeding, what do you put there? You don't put 16 gauge, no, 26 gauge. You usually will put like 16 or 18 gauge. Okay, you put 16 or 18 gauge. 26 is too small. Every time they give you a question and the patient is bleeding, never choose anything less than anything smaller than 20 gauge. Remember, the smaller the normal, the bigger the IV. So 18 gauge is bigger than 20 gauge in terms of its function, but the normal is smaller. 16 is the biggest. So don't pick anything below bigger than 20 in terms of the normal, but in terms of the size. So this is not indicated. The only thing that is indicated here is the C-section. What is contraindicated? This and that. So you don't need to put 26 gauge. You don't need to take the patient to CT scan because they're already in shock. There's nothing you're going to gain from it. The patient needs to go into C-section. Once again, anybody bleeding, choose 16, 18. If there's 20 gauge there and there's no 16, 18, choose 20. But any normal bigger than 20, don't pick it. The same thing. Pancreatitis, bleeding. You want to choose 28? No way. We're not choosing 28. 28, so this will be 28. We are not choosing 28. 28 is contraindicated. Do we want to type and cross this patient? What do you think? Patient is bleeding. We got to prepare to transfuse the patient. So this is indicated. You want to give this patient ice chips? Tell me. We have to give the patient ice chips. Patient who is in bleeding will go into what? Hemorrhagic shock. Does not need ice chips. You want to get this patient to walk around 3 times? It's not indicated. It's contraindicated. It's in shock. This patient is in shock. There is no need to take this patient out and go walk. So it's contraindicated. Same thing. Sepsis from what? Roux-en-Y gastric bypass, right? Sepsis from Roux-en-Y. So they have sepsis inside. So they have perforation and they septic. You want to feed the patient? They say MPO. You want to give them cefotetan? This is antibiotic. You want to give them IV fluid? You want to transfuse 2 units of packed red blood cell. If I have sepsis, of course, don't feed me. I need some antibiotic. I need some IV fluid. There's no indication this patient is bleeding. So don't choose that. It's contraindicated. They need surgery when they get to surgery. But transfusion 2 unit right now is irrelevant. Patient is septic. Let's fix the sepsis. Sepsis control does not include blood transfusion. So don't overselect. Like I said, use the diagnosis and know what you need to do. Same thing. Appendicitis now as ruptured. I said stop ceftriaxone. You want to stop antibiotic? You want to get another CT scan? Or you want to feed the patient ice chips? Think about it. Patient is septic. It's going to be septic. He has a rupture of the appendix. We're not going to stop antibiotic. We're going to get a CT to make sure they've ruptured. If there's abscess there, we can drain it. We're not going to feed this patient ice chips. And so this is, you go through the process. You see, we've answered all the questions. We've talked about it. You know what is the problem is. You just manage it. You manage it. You've seen this before. You've seen this before. Okay? You've seen this before. Like this is presented in the different form. So this is the presentation. This is the way you have 4 patients that you have to flip your head back and forth from each patient and the kind of condition that they have and manage them. And the last question. This is what we have. I pick question, patient number 3. I've given you the answer already. Number 3. Underwent successful surgery. 2 days later, client reports shortness of breath. This is the temperature, blood pressure, heart rate, respiratory rate, and saturation. Which of the following is a priority action? Prioritization once again, but presented in the different form. You can't answer the question without spending time to figure out what is wrong with the patient. I always say that. Don't ever answer a question without you not knowing what the patient is suffering from. You read it from the back. Which of the following is a priority? I've given you vitals. Patient underwent surgery. All of a sudden, shortness of breath, temperature, blood pressure, tachycardia, respiratory rate of 25, and saturation of 95. You know patient 3. Patient 3 is a Roux-en-Y bypass patient. If a Roux-en-Y gastric bypass patient had surgery 2 days later, it's all content. I mean, trust me, like if you master this, the NCLEX will become easy. So if you need help, you check out that NCLEX. I just release a bunch of, usually when I do video, I don't hide any content. It's just blasted. When you watch it, you get shocked how much of content in it. Because it should be like that, easy to follow. The books are so difficult. But when you listen to yourself, oh, now I understand it. The same thing. A bunch of buzzwords. You have to make the diagnosis. If you make the diagnosis, this is nothing. Did you figure it out? 2 days surgery, shortness of breath, tachycardia, low-grade fever, tachypnea, saturation 95 on 2 liters. Those are the signs and symptoms of a specific problem. The first one I presented it, the patient has a leak. I told you there's 2 things you worry about gastric bypass patient is anastomosis leak and what? PE. But all of them, the signs and symptoms look the same, but you have to look at it. You know, I never tell you about any abdominal symptoms. That means I don't want you to think about leak. I give you enough information to think about something else. And this sounds like what? Pulmonary embolism. If it's pulmonary embolism, what will you do then? What will you do? You give the patient antibiotic? Do you call rapid response? Do you order Doppler ultrasound of the leg, or you get a CT of the chest with contrast? Test taking strategy, right? I know it's PE. The fever is a trap. When you have PE, you have fever, low-grade fever. Okay? You can get fever at 101.5. It's possible for this patient. So he has PE. Antibiotic is not treating PE. Don't get distracted by the fever. If you tell me it's PE, then you shouldn't be looking at an antibiotic. There's nothing here that requires rapid response. They'll call you and say, what do you want us to do? Fix the patient yourself. Then you left with 3 and 4. You have to think. When I said be sharp, that's what I mean. Think about it. Which of this will help you to prevent the patient dying? 1 second. When you go and get ultrasound of the leg, yeah, it will tell you as DVT, but does that tell you? It tell you this probably as emboli to the lung, but you don't know that. You assume that. But if you get a CT of the chest, it gives you a diagnosis. It can even go all the way to the leg and be able to figure out what the patient is, and it can manage. So CT of the chest is better than ultrasound of the leg. Although it can give you an idea, oh, you have a DVT. But most of the time, the clot may already gone. That is what has embolized to the lung. So there will be no clot there. Test taking strategy. This is a 6th case study, but as you saw, it was presented in a different way, just to help you guys out, so that in case you see, you don't panic. You say, what is this? 4 patients in 1 case study. You manage all of them at once. That means you're good. If you do that, you're good. You're thinking. They're trying to let you flip your head back and forth. Like you treat each patient different and you manage them and you analyze them. You try to do prioritization. You do select or apply. And so the question is loaded. It has everything. You do some teaching, you see intervention, and you do select apply based on the problem. Based on this, you manage it. Based on this, you manage it and that. And then at the end, I pick one of them to see your test taking strategy and thinking, and figure out what is wrong with them. So if you go and take it and they give you 4 OB patients, do the same thing. They give you 5 GI patients, do the same thing. Like I said, bring your prioritization and bring your content and manage each patient and figure out what complication associated with them and manage it. That's all. That NCLEX is out. You have a good day and happy Thanksgiving in advance. Take care of yourself. Bye-bye.